a man who came in with what, well, doctors thought was a stab wound.
Well, and it was. He was at a Halloween party in the middle of San Francisco, arrived in a hospital he's stable, doing well. They did the standard search him head to toe, found a single 2-inch size wound in his abdomen. Vital signs were okay. He was feeling okay, drunk and babbling. And the trauma team has a choice at that point. You either get proper imaging, you go through their medical history and make sure you haven't missed anything, or you rush straight to the operating room because this person could die on you right now. Well, he was stable, and given a stab wound that didn't look too bad, they decided to go through with imaging. And then 5 minutes later, he crashed right in front of their eyes. He lost his blood pressure and started to die on them. They then switched gears, rushed him back downstairs, and it was all they could do to save him. He was in the hospital for over a week from a stab wound that turned out to have gone through his belly. He was over 200 pounds, almost 1.5 feet through him into his aorta, lying in the back of his body. And a surgeon who was there had been a surgeon in Vietnam, and he said, I hadn't seen a wound like this since Vietnam. And it turned out he was right. They learned afterwards they forgot to ask one question. What did the weapon look like? Turned out he was at a Halloween party where the other guy was dressed as a soldier and stabbed him with a bayonet. And if they had been able to not miss that one question, what does the weapon look like, they would have figured out this was a much more dangerous wound. I tell that story because there are 1,000 ways that things go wrong in a complex world like in medicine. And we have had a hard time trying to grapple with the reality that the knowledge is beyond the capacity of any one person to hold it in their head. There are technologies that we've tried to introduce. We've pursued very expensive solutions, but what we've not recognized is that we can pursue an idea like checklists, the way airlines have it. We should have a checklist for virtually every high-risk step that we have in medicine. We should identify what the best practices are and how to make it usable at the front lines. And we've forgotten that this is part of the science of what it means to make better health care and lower cost. The surgery checklist we came up with for operating rooms cost us less than $1 million to create and test in 8 hospitals around the world. And the savings that come from actually implementing it in our hospitals would be greater than $25 billion if we use it. But we've also had a cultural resistance. There are less than 20% of American hospitals that have adopted the surgical checklist that we've got. Interestingly, in health systems that have national health care, they've moved faster to adopt it. France, just 4 weeks ago, went live in all 8,000 of their operating rooms with surgeons using the checklist to reduce harm and care.
I want to read to you from an article published in the British medical journal The Lancet last August, and it's co-written by a number of people, one of them Peter Pronovost, whom you credit in the book for creating the the checklist for central line infections. And they're talking about the Michigan Keystone ICU initiative, and this is what they write. Quote, the problem is that the story may well have been oversimplified. They're talking about the media coverage. The emphasis on checklists is a distraction from the plot that diverts attention from how safer care is really achieved. Safer care is achieved when all 3, not just one, of the following are realized. Summarize and simplify what you do, measure and provide feedback on outcomes, and improve culture by building expectations of performance standards into work processes, they say. They go on to say, we propose a widespread deployment of checklists without an appreciation of how or why they work is a potential threat to patient safety and to high-quality care. What's your response to that?
They're completely right. The part of what's fascinating about the checklist ideas is if we just drop tick boxes into place and you have people just going to their paperwork and not thinking about the patient, we've not solved the problem. There are good checklists and bad checklists. There are ones that turn people's minds off and become central command and control. This is about making teams having an aid that actually makes them more effective and not forgetting the dumb stuff. And then second, we do have a culture issue here. We see it in medicine as a form of weakness. You see a doctor in the office, and imagine if the doctor said, let me look this up in a textbook, and pulled the textbook out. You lose confidence in them. We want to pretend we are infallible.
I gain confidence in the person.
Exactly. That we have got to, we've now started to recognize that we actually are better off saying to people, I could get this wrong, and we need to check on it. But what he points out is, just creating a checklist that simplifies what needs to happen in every office appointment doesn't mean people use it. It doesn't mean that we have changed our culture to recognize that we are in the midst of redesigning our system.
Sharif mentioned the Michigan system and the test that was done there. I was fascinated by what some of the poorest hospitals in the country did in Detroit. Talk about what the adoption of the system, what it meant, and what it meant for the doctors there. And the hospitals that could least afford any kind of change, some might have argued.
Yeah. We have 2 million people who pick up infections in hospitals in the United States because somebody didn't wash their hands. And so for one of the most common infections in intensive care units, where the intravenous lines get infected, what was recognized that if you made a checklist that said, before the line goes in, that you've made sure everybody has washed their hands, a hat, mask, glove, gown is on, sterile drapes around the patient, soap to clean the site had gone in, that this would reduce their infections. And when they put it in place, it reduced their infections in the state of Michigan by more than 2/3. The average hospital in Michigan has 0 infections now from these kinds of lines in any given quarter. The worst hospital in Michigan has a lower infection rate than 90% of American hospitals.
Which hospital?
Well, at this point, it's not clear which one is the worst, but I visited Sinai Grace Hospital in inner-city Detroit, one of the most depressed, struggling public health systems in the country, that had managed to improve their infection rates under struggling conditions of poor resources in extraordinary ways. And what's interesting about it is, to make a checklist like this work, it requires a shift in power. What it means is allowing a nurse to tell a doctor, I think we didn't finish all those 5 steps that we have to go through. And there comes a moment when the doctor will then say, I'm the doctor, and I decide what goes on here. And if an administration doesn't back them up and say the culture of a hospital has changed, we have a team, and the nurse can actually say, no, wait a minute, this is a moment that we have to halt because we could harm someone. A lot of these ideas are around creating the power for a group of people to work effectively.
One of the examples you give in that Detroit case is that they included in the central line kit, after a while, soap. Or the antiseptic. Yeah,
it's one of the bizarre things that you then work backwards. You realize, of course it's frustrating at the front lines delivering care, because if you want to follow through on those 5 steps, for example, putting soap to clean the site where the line goes in, the proper soaps weren't actually in the kits. You needed people at a system level to go back to the manufacturers and say, the best care requires the right size drapes, the right kind of soap, and it's not in there. And that kind of change wasn't possible until you decided as a state, this is what we have to do right.
Dr. Atul Gawande, I just want to switch gears for a moment here. In addition to being an author, practicing surgeon, and a professor at Harvard Medical School, in your plenty of spare time, you're a staff writer at The New Yorker, and many of your articles have been very influential, perhaps none more so than one you wrote in June about health costs in McAllen, Texas. It became apparently required reading at the White House. President Obama convened a meeting of his aides to discuss it. He cited it in a speech before the American Medical Association. Talk about what you found in McAllen, Texas, where it had the highest cost of health care in this country, and what that meant for health reform in this country.
I didn't really understand what we needed to do to control costs. We've had solutions about what to do about coverage for 3 decades that you could almost pull off the shelf, and we're arguing about which one we want off the shelf. But what do you do about cost? I decided the way to try and answer this was look at the county that's spending the most money in the United States for health care, for Medicare, and that was in South Texas, in McAllen, Texas. And I visited doctors there, and I said, what do you think is going on? I compared that county, which is a border county, very poor, one of the poorest counties in our country, large Spanish-speaking only population. You have a high rate of undocumented immigrants. But El Paso, Texas is just the same, and El Paso costs half as much per person for health care.